Hello everyone, I'm Dr. Ajit Khilnani, and in this video I'll be discussing in detail about chronic suppurative otitis media. Now this session is primarily targeted to mostly undergraduate and postgraduate students in ENT, and chronic suppurative otitis media, it is a very important topic because most of the times there are many questions related to this topic in theory examination, in practical examinations, as well as case-based examinations. So let's see what is chronic suppurative otitis media. Now the objectives of this session will be all of you should be able to define chronic suppurative otitis media. Then what is the classification that is used for chronic suppurative otitis media, and to know what is the etiology, clinical features, and management of chronic suppurative otitis media. Now, if you have any questions or comments during the session, then you may please put it in the comment box and I'll try to answer your queries later on. Now, wherever required, I will be highlighting the important points. So the definition. Now, chronic suppurative otitis media, it is a long-standing infection of a part or whole of middle ear cleft, which is characterized by ear discharge and a permanent perforation. Now, important points here is it is an infection of any part of the middle ear cleft. So there's a difference between middle ear and middle ear cleft that I'll tell you later, and it is characterized by discharge. So the primary symptom of the patient with CSOM, it is ear discharge and a permanent perforation. Now, perforation is called permanent when the margins of the perforation are epithelialized, so that there is no chance that it will heal on its own. So that is called a permanent perforation, a perforation with epithelialized margins. Chronic suppurative otitis media, it is more commonly seen in poor countries with low socioeconomic standards and poor nutrition. And it affects both genders and it can affect any age group. So this is something about the definition and demographic details of chronic suppurative otitis media. Now this figure depicts the middle ear cleft. So the central part. So we can see this central part, this is the middle ear. But if we include the attic, that is epitympanum, the Otitis, the antrum, the mastoid hair cells, along with eustachian tube. So this whole entity, it is called middle ear cleft. And chronic suppurative otitis media, it is infection of any part of this middle ear cleft. Now the classification of chronic suppurative otitis media. So various terminologies or various classifications have been used since long. The common ones are CSOM can be tubotympanic or it can be atikventral. Sometimes tubotympanic is also referred to as safe otitis media, and atikventral is called unsafe. Tubotympanic is sometimes called benign, and atikventral it is sometimes called dangerous. However, the latest classification is division of chronic otitis media into either a mucosal disease or a squamosal disease. So mucosal and squamosal, these are the two types of chronic suppurative otitis media as per the latest classification. Now, if we look at the mucosal type of chronic otitis media, it is further divided into three types depending on the activity of the ear. So if the discharge is present along with the perforation, then it is called active mucosal otitis media. It is a wet perforation. If the perforation is there but there is no discharge, it is called inactive mucosal otitis media, that is a dry perforation. Sometimes there is no perforation and the tympanic membrane has healed on its own. Then it's called a healed mucosal disease. An example is like adhesive otitis media. Now, healing of the tympanic membrane can occur in various ways. Suppose there is a perforation which heals on its own. So generally what happens, we know that there are three layers of a tympanic membrane. the outer epithelial, middle fibrous, and inner mucosal. However, during spontaneous healing, the middle fibrous layer, it fails to regenerate or develop. So there is only outer epithelial and inner mucosal layer in the healed tympanic membrane. That is why it is also sometimes called dimeric membrane. Another method of healing can be formation of a sclerotic patch. What we called is tympanosclerosis. So healing process can occur either through formation of a dimeric membrane or formation of a tympanosclerotic patch. So these are the three types of mucosal chronic otitis media. The second part, that is squamosal chronic otitis media, it is further divided into two parts, active and inactive. Active squamosal means presence of cholesteatoma or presence of active discharge, flakes in the posterior superior or aticoantral, the attic region. Inactive squamosal means that there is a retraction pocket in either it can be either in the attic region or it can be either in the posterior superior region. But that retraction pocket, it is shallow, it is dry, it is non-progressive. That is why it is called inactive squamosal disease. However, it can progress, it can remain as inactive as such, or it can progress to active ear discharge if there are recurrent infections. So this retraction pocket, it is a precursor of cholesteatoma. So ultimately, with repeated infections, it may progress to the formation of active squamosal disease, for example, cholesteatoma. So this is the classification of chronic otitis media. Now we'll start with tubotympanic chronic suppurative otitis media, or what we saw, the mucosal type of CSOM. Now it is associated, this mucosal type, it is associated with anterior-inferior part of the middle ear cleft. So as the name suggests, tubotympanic. So tubo means eustachian tube and tympanic means the mesotympanum, the middle part of the middle ear. So the pathology, it reaches the middle ear through the eustachian tube. That is why it is called tubotympanic type of otitis media. The etiology of CSOM of mucosal type is most of the times it is sequelae to acute otitis media following the exanthematous fever like measles or mumps. So recurrent attacks of acute otitis media can ultimately progress to the mucosal type of chronic otitis media. Then ascending infections via the eustachian tubes. And also it has been shown that sometimes because of allergy also, mucosal type of CSOM can arise, and that allergy can be to food products like milk, eggs, or fish. So the pathology that is seen in mucosal type of chronic otitis media is most commonly we see a perforation, and it is located in the pars tensa of the middle ear. So in the subsequent slides, we'll see which part of the tympanic membrane is called pars tensa. It is central perforation, and the size and the position of the perforation varies. So now the question is, what is a central perforation? A perforation is called central when it is surrounded by the remnants of the tympanic membrane from all sides. That is called a central perforation. And depending on the size and position, the perforation is classified. We'll see in subsequent slides. Now here, if there is no discharge or if the ear is dry, then the middle ear mucosa may be normal, or the middle ear mucosa may be edematous or vascular or velvety if the disease is in active stage, that is, discharge is there. Sometimes a polyp is seen arising from the middle ear in cases of mucosal CSOM, but that polyp is pale. It is non-fleshy, non-vascular. Regarding ossicular chain, most of the times in mucosal type of chronic otitis media, the ossicular chain is found to be intact or partially eroded but mobile. And when necrosis occurs, the long process of incus, it is the most common bone to get necrosed in ear pathology. The reason is that it has a limited vascular supply, so it is easily necrosed by disease. Another pathology that can be seen in mucosal type, as I explained earlier, is formation of a tympanosclerotic patch. So on otoscopic examination, we can see a perforation along with a white chalky patch which can be present either in the anterior part of the, either anterior to the handle of malleus, or it can be in the posterior to the handle of malleus. Then during surgeries, we may also find during ear surgery that there can be fibrosis of the soft tissue of the middle ear, or there can be formation of adhesion bands in the middle ear, which can lead to the ossicular fixation and conductive hearing loss. So this is how the mucosal type of chronic otitis media affects the various structures in the middle ear. Now, clinical features. So the bacteriology of mucosal type is Pseudomonas aeruginosa, Proteus, E. coli, Staphylococcus aureus. These are the common bacteria that have been isolated from the discharge of mucosal chronic otitis media. The clinical features. Now, the primary symptom of the patient with CSOM, it is ear discharge. The characteristic features of ear discharge of mucosal type of chronic otitis media is that it is non-offensive, that is non-foul smelling. There is no foul smelling in the discharge of mucosal type of otitis media. However, if there is superadded infection, then sometimes it can have a foul smell. It is mucoid or mucopurulent. Now, mucoid discharge means it has a thick and sticky consistency, and it is suggestive of if the discharge is mucoid, then it is suggested that it is coming from the middle ear, because the mucus secreting glands and the goblet cells, they are present in the middle ear. So mucoid discharge, it is suggestive of a middle ear pathology. It can be mixed with pus, so it is called mucopurulent. Then it can be constant or it can be intermittent. Now, in mucosal type of chronic otitis media, generally the discharge is intermittent. It means that it is relieved by medication, and whenever there is an acute attack of upper respiratory tract infection, the discharge reappears. Or if there is water entry into the middle ear which causes infection, then again the discharge reappears, but it is intermittent. The next common symptom is hearing loss. Hearing loss is most of the times of conductive variety, and because the ossicular erosion is less seen in mucosal type, the hearing loss also, it is of mild to moderate degree, and it's rarely exceeds 50 decibels, average hearing loss. And sometimes a contrary phenomena is seen where the patient will hear better in the presence of discharge. Now, this can be explained by the fact that the discharge is present near the round window. That is called round window shielding effect. So it will cover, the discharge covers the round window. So whatever sound the patient hears, it directly hits the oval window as in normal physiological uh, person. So that is why the patient will hear better in the presence of discharge. That is called round window shielding effect. On otoscopic examination, we see a perforation in the tympanic membrane in cases of mucosal type of chronic otitis media. Now that perforation, it is always central. We saw what is central. Central means that the perforation is covered by the remnants of the tympanic membrane from all sides. Then through the perforation, we can see the middle ear mucosa, which can be pale. If it is infected or acute infection is there, it can be red and edematous. So this is a schematic representation of the tympanic membrane. This is a figure of a right-sided tympanic membrane, because we can see that acute angle is being formed on the right side. The tympanic membrane, it is not located exact vertically, but it is a tilted structure, making making an angle of around 45 to 55 degree with the horizontal, like this. So this is a tympanic membrane of the right side. Now here we see that it has been divided into 4 quadrants. So the first line, it is vertical line along the handle of malleus. It's an imaginary line. And the second line, it crosses the first line at right angle at the level of umbo. That is the lowermost part of the handle of malleus. So these 2 lines, they divide the tympanic membrane virtually. These are not present in over the tympanic membrane. These are virtual just to understand the anatomy and to describe the pathology. It divides the tympanic membrane into 4 quadrants: anterior superior, anterior inferior, posterior superior, and posterior inferior. Now here we can see that cone of light, it is always present in the anterior inferior quadrant because the anatomical location of tympanic membrane is such that whenever light falls over the tympanic membrane, now that light can be light from headlight, light from a Bull's lamp and head mirror, or light from otoscope, or light from endoscopes, that is oral endoscopes. In all these examinations, the anterior inferior quadrant will be illuminated and a cone of light will be seen in anterior inferior quadrant. So this is just a schematic representation to visualize the normal tympanic membrane. The outermost part of the tympanic membrane, it is fibrocartilaginous in structure, that is called annulus. Now here we see that there are two mallear or malleolar folds, one arising from the anterior part of the handle of malleus and another arising from the posterior part of the handle of malleus. The part of the tympanic membrane which is located above these malleolar folds, it is called pars flaccida or shrapnel's membrane. And the part of the tympanic membrane which is located below these malleolar folds, this is called pars tensa. Now here we are talking about mucosal type of chronic otitis media. So here the perforation, it is located in pars tensa region. It can be in any quadrant, but it is located in pars tensa region. So whenever on otoscopic examination we see a perforation, we need to describe the perforation under these headings: the type, number, size, margin, and shape. So let's see each classification. Type of perforation. It can be a central perforation, it can be a marginal perforation, or it can be an attic perforation. So what is a central perforation? So this is a figure showing a central perforation. Now here we can see that this is present in pars tensa. So this whole region is pars tensa and we can see a perforation here. It is surrounded by tympanic membrane on all sides. So these are the remnants of the tympanic membrane which are present all along the margins of the perforation, and it is seen in tubotympanic type of um, otitis media, that is mucosal type of otitis media. So we see that a central perforation is a characteristic feature of mucosal type of otitis media. Second type of perforation, it is a marginal perforation. Now here we can see that it is not surrounded by the tympanic membrane of all sides. On all sides, some part of the margin of this perforation, it is being formed by annulus. So that is why it is called a marginal perforation. Now this type of perforation, it is associated with secondary acquired cholesteatoma. What is that? We'll see later in this session, secondary acquired cholesteatoma. But here we can see that there is a marginal perforation. The third type of perforation, it is attic perforation. So as I told you that the part of the tympanic membrane which is located above these two malleolar folds, anterior and posterior, it is called pars tensa. Oh, sorry, pars flaccida. A perforation present in the pars flaccida, it is called attic perforation. So this is basically the attic region or epitympanum, what we call. And such type of perforation, it is generally associated with primary acquired cholesteatoma. Again, we'll see what is that in the subsequent slides. So these are the three types of perforations: the central, the marginal, and the attic. The second point by which under which we describe a perforation, it is the number of perforations. So most of the times we see a single perforation. However, typically in tuberculous otitis media, there can be multiple perforations. So this is an endoscopic picture of ear. So here we can see that there are two perforations seen, which are there is a thin band of remnants of the tympanic membrane between these two tympanic perforations. So multiple perforations can be seen in tuberculous otitis media, or sometimes they are also associated with trauma. So this is number. The next is size. Now, depending on the size, the tympanic membrane perforation can be divided into small, moderate, large, subtotal, and total. A small perforation involves one quadrant. A moderate perforation involves two quadrants. A large perforation involves more than two quadrants. In subtotal perforation, whole of the tympanic membrane is involved. It is absent, except annulus. And if annulus is also lost or destroyed, then it is called a total perforation. So let's see how these perforations are divided based on the size. So here we can see that only one quadrant is involved. In this case, it is anterior-inferior quadrant, so it is a small perforation. Here we see that anterior-inferior as well as anterior-superior, oh sorry, posterior-inferior. So anterior-inferior and posterior-inferior, both quadrants are involved. So it is a moderate perforation. This is a subtotal. Now here we can see that whole of the tympanic membrane is destroyed. Whole of the tympanic membrane except the annulus. So annulus is present. So this is a subtotal perforation. And here there is no annulus also. So this is a total perforation. That is how we classify a perforation depending on the size of the perforation. The fourth quality to be noted is margin. Now here in this endoscopic view, we can see that the margins of this perforation are very smooth. So smooth margin, it is indicative of chronic otitis media. And in the below figure here, we can see that the margins are congested, they are irregular, they are ragged. So such type of margins are a feature of traumatic perforation. So we should be able to differentiate a traumatic perforation from a disease perforation by looking at the margins. In the above picture here, we can also see that this is white chalky deposit. So this is the tympanosclerotic patch. And there is irregular mucosa which is seen in the middle ear, in the medial wall of the middle ear. So this arrangement of cells, it is called coralization. It is a normal phenomenon. Next feature of a perforation, it is the shape. Now, most of the times a perforation can be either a circular or oval shaped perforation. However, sometimes two oval shaped perforations, they coalesce or they join to form a kidney shaped perforation. And in the previous slides, we saw that if the perforation is traumatic, then generally there is no fixed shape and it is very irregular in shape. So this is regarding shape of the perforation. So now if we come across a case of a mucosal type of chronic otitis media, we make a diagnosis based on our history, based on the symptomatology, and based on our otoscopic examination. So what are the investigations that we need to do? So the first thing is we need to examine the patient under the microscope so that we can have more detail of the condition of the middle ear and the characteristic of the perforation. If required, if there is discharge, we need to clean that discharge also under microscopic vision. Next thing we do is we get an audiogram done. Now this is done to know the type of the hearing loss, to know the degree of the hearing loss, and also to document the hearing loss and to compare the preoperative hearing loss with postoperative hearing thresholds. So this is the importance of getting an audiogram done. So in the first visit of the patient, we can send the charge for culture sensitivity. Then if required, if we are planning a surgical management, then depending on the extent of the disease and our clinical examination, either we may go for X-ray method, which is the Schiller's view, or if required, we also need CT scan to be done, HRCT temporal bone, to visualize the details of the disease extension and the mastoid ear cell system. The management, so the primary aim of any ear surgery, it is to eliminate the disease. And secondary aim, it is to correct the hearing loss. So initial management includes cleaning of the ear, that is called oral toilet, which can be done by dry mopping using earbuds, or it can be done by suction cleaning, or sometimes if the discharge is very thick, syringing can also be done. Then eardrops, antibiotic eardrops are started, which contain neomycin, polymyxin, gentamicin. So these drops are started, and if required, systemic antibiotics. To start with, we generally start with broad spectrum antibiotics like amoxicillin, azithromycin, cefadroxil, amoxicillin with clavulanic acid. By the meantime, we get the culture sensitivity report. Then, if required, we can change the antibiotic accordingly. And we also instruct the patient to avoid water entry into the ear and to avoid hard nose blowing, because when the patient blows the nose hard, then because of the creation of the pressure, the discharge may ascend into the middle ear through the eustachian tube. So that is avoided. And if there are any contributory causes, for example, if there are enlarged tonsils, enlarged adenoids, if there is symptomatic gross deviated nasal septum, or if there is associated sinusitis, then these are also to be treated simultaneously, because these are the primary source of infection which ascends into the middle ear through eustachian tube. So these needs to be addressed rigorously before planning any surgical management of ear pathology. So what is the surgery that is done? If there is a big polyp, then polyp can be removed initially, but precaution to be taken here is that ear polyps, they should never be avulsed. That is, they should never be pulled out blindly, because they may be arising from some important structures in the middle ear like fallopian canal, promontory. So it can cause damage or facial palsy to the patient. So they are cut at the base with a sharp instrument, a microforceps, sharp microforceps. If there are granulations, they can also be removed, or they can be sometimes cauterized with trichloroacetic acid. And the definitive management, it is myringoplasty. Now here we can see that there are two terminologies shown here. One is myringoplasty, other one is tympanoplasty. So if we are planning only the repair of the tympanic membrane perforation, then it is called myringoplasty. And if it is also associated with ossicular reconstruction, that then it is called tympanoplasty. So we can say that tympanoplasty is equal to myringoplasty plus ossicular reconstruction. So tympanoplasty is the surgical treatment of choice for mucosal type of chronic otitis media. And after the initial medical management, when the ear becomes dry, then surgery is planned generally 6 to 12 weeks once the ear becomes dry. So there are different types of tympanoplasties, and there's a Wolstein classification. In type 1 tympanoplasty, the ossicular chain is absolutely normal. So only repair of the tympanic membrane is done. So we can say that it is like myringoplasty. In type 2 tympanoplasty, there is partially eroded ossicular chain. So sometimes the malleus can be partially eroded, sometimes incus can be partially eroded. However, the chain is functional and mobile. So again, the tympanic membrane or the graft, it is placed over the remnants of the ossicles. Type 3, here we see malleus and incus are absent, but stapes is functional and normal. So the graft is kept over the stapes head, which is called type 3 tympanoplasty or myringostapedopexy. Myringostapedopexy. We are putting the graft over the stapes, myringostapedopexy. Type 4. Now here we can see that the malleus is absent, incus is absent, as well as stapes superstructure is absent. But stapes footplate is present. So we are exteriorizing this footplate so that the sound waves, they directly hit the footplate, and we are protecting the round window or shielding the round window. So that is again called round window shielding effect, where the graft is placed over the stapes footplate, but that staped footplate, it is exteriorized to the external ear. Then type 5. Here, though stapes is present, but it is non-functional. It can be fixed. So it is of no function. So a separate window, it is created mostly in the horizontal semicircular canal, so that the sound waves preferably enter the inner ear through that fenestration. So that is called type 5 or type fenestration surgery. So these are the five types of tympanoplasties depending on the ossicular erosion, and it is Wolstein classification of tympanoplasty. So with this, we finish with mucosal type of chronic otitis media. Now let's start the aticoantral type or the squamosal type of chronic otitis media. And we will also keep on noting the differences between these two pathologies. So aticoantral. Now, as the name suggests, it involves the atic and the antral part. That is the posterior superior part of the middle ear cleft. Atic, antrum, the posterior tympanum, along with the mastoid ear cells. In mucosal type, we saw it was the anterior inferior part which was involved, while in squamosal, we see it is the posterior superior part. Now, this pathology, it has a bone eroding property. That is why the chances of complications are more with squamosal type of otitis media as compared to mucosal type. And that is why it is also called unsafe type or dangerous type of chronic otitis media because of the bone eroding property of the disease. Now, this squamosal type, it can manifest in different ways. The commonly what we understand, or by default what we consider as squamosal type, it is cholesteatoma. Other ways in which this disease can present, it is osteitis, inflammation of the bone with formation of granulation tissue. It can be a polyp. Now here we see that there is a red polyp. Now if you remember in mucosal, we saw it was a pale polyp. So that is one difference. Then ossicular necrosis, it is more commonly seen in mucosal, in squamosal type of chronic otitis media. And hearing loss, it is more than mucosal type. However, sometimes the disease, it bridges the, uh, it acts as the medium for the conduction of the sound, just like ossicles. In such cases, the patient will have no hearing loss or less hearing loss in spite of disease. So those patients, they are called cholesteatoma hearers, where the disease, that is cholesteatoma per se, acts as a conducting medium for the sound. So initially we will feel that this patient is having less hearing loss. So maybe the pathology will be less, but on surgery, we find there's a big cholesteatoma sac inside the middle ear or attic antrum. So such patients, they are called cholesteatoma hearers. Another way in this disease can present, it is formation of cholesterol granulomas. So basically, this is the granulation tissue with foreign body giant cells surrounding the cholesterol crystals. So these are the different ways in which the squamosal type of chronic otitis media can be seen. Now, as I told you that most commonly we see cholesteatoma. So what is cholesteatoma? It is a misnomer actually. So neither it is made up of cholesterol or nor it is a benign tumor as the suffix suggests. So it's a misnomer. In simple language, if we understand, then it is skin in the wrong place. It means that in middle ear cleft, there is uh, uh, presence of keratinizing squamous epithelium in the middle ear cleft. Normally, this epithelium is not present anywhere in the middle ear cleft. It is either lined by ciliated columnar or cuboidal cells. But if because of any reason, and what are those reasons, we'll see subsequently. If because of those reasons, the squamous epithelium, the keratinizing squamous epithelium enters into the middle ear cleft, then it is called cholesteatoma. Some other terminology is given to it is epidermosis or keratoma. So let's see this in detail. If we see the structure of the cholesteatoma, then this is the temporal bone, the outer part, and then comes a layer of fibrous stroma, then matrix, which contains the stratified squamous epithelium, and the central mass of the sac. It is called keratin mass. So centrally there is keratin mass, which is covered by this squamous epithelium, and it keeps on eroding the temporal bone through fibrous stroma. So that is the structure of cholesteatoma. Now, types of cholesteatomas, they can be either congenital or it can be either acquired. Acquired is further divided into primary acquired or secondary acquired. Now, if you remember the mucosal disease, there we saw that if there is a marginal perforation, it leads to the formation of secondary acquired cholesteatoma. And if there is an attic perforation, it may lead to the formation of primary acquired cholesteatoma. Now, what is congenital cholesteatoma? Congenital cholesteatoma is seen because of the embryonic epidermal cell rest in the middle ear cleft. So generally during development, what happens? Some epidermal cells, they remain in the middle ear. So we can consider it as a developmental anomaly. And as the age increases, that epidermal cells, they keep on proliferating and ultimately they form cholesteatoma. Now, there is one criteria, Levinson's criteria, to diagnose the congenital cholesteatoma. And it is seen as a white mass behind the tympanic membrane with conductive hearing loss. So this is one of the criteria of Levinson, presence of white mass behind the tympanic membrane with conductive hearing loss without any prior history of any ear discharge or ear perforation. So typically how these patients come, a child comes in the OPD and the parents say that the child is not hearing properly in school or at home also. So on otoscopic examination, we may see a white mass behind the intact tympanic membrane. So that is a typical feature of cholesteatoma. Now, adult cholesteatoma or acquired cholesteatoma, it is mostly seen in attic region. It is mostly seen in mastoid air cell or attic region. But this congenital cholesteatoma, it is more commonly seen in middle ear, petrous apex, or cerebellopontine angle. So these are the three areas where congenital cholesteatoma is more commonly seen as compared to the acquired cholesteatoma. So this can be a picture in case of congenital cholesteatoma. Here we can see that there is a white mass which is seen behind the normal intact tympanic membrane in a child. So this is how congenital cholesteatoma may look. Primary acquired cholesteatoma. Now in primary acquired also there is no history of prior otitis media or any perforation, and the cholesteatoma then develops. So various theories which support the development of primary acquired cholesteatoma. First is Whitmack's theory, which says that initially there is formation of the retraction pocket, and with time this retraction pocket keeps on enlarging and ultimately gets infected and leads to the formation of cholesteatoma. Second theory is Rudy's theories, which say that the basal cells which are present in the tympanic membrane inner side, they can they increase in number and it causes basal cell hyperplasia, which ultimately leads to the formation of cholesteatoma. Or Sede's theory, like hyperplasia, it is the metaplasia of the basal cell, which can be because of the repeated infections. So Whitmack's, Rudy's, and Sede's, these are the theories which uh, explain the formation or development of the primary acquired cholesteatoma. Then comes the secondary acquired cholesteatoma. Now it is secondary to already pre-existing ear pathology. So there are again two theories, Haberman's theories, which say that in secondary acquired cholesteatoma, there is a pre-existing perforation, and through the margins of that perforation, the epithelium invaginates and reaches the middle ear. So that is Haberman theory, pre-existing perforation. The saddest theory that we saw previously, again, it can also be there in the formation of secondary acquired, that is metaplasia due to the repeated infection. So these two theories, they explain the secondary acquired cholesteatoma. And presence of congenital cell rest explains the formation of congenital cholesteatoma. So basically say there are 5 theories of formation of cholesteatoma. The first is congenital cell rest, then Whitmack's, Rudy's, Sade's, and Haberman's theory. Now the clinical features of squamosal type of otitis media, again the primary symptom is the ear discharge. However, the ear discharge is scanty. Now depending on the amount of the ear discharge, we can say that the discharge is either profuse or moderate or scanty. A profuse discharge means it is coming out of the ear canal. So the patients will say that the pillow gets stained or their clothes get stained sometimes. So that is called a scanty ear discharge. Oh, sorry, profuse ear discharge. A moderate amount ear discharge means it is present in the ear canal, but it is not coming out of the ear. And scanty means it is very minimal in amount. And when the patient or the examiner cleans the ear with a earbud, then the tip of the bud gets stained. So that is scanty discharge. Now, profuse and moderate discharge, they are most of the times they are characteristic feature of mucosal type of otitis media. But scanty discharge, it is a feature of squamosal type of ear discharge. Second feature of ear discharge in squamosal type, it is foul smelling. Now in mucosal we saw it was non-foul smelling. Here it is foul smelling. The reason is that the disease, the cholesteatoma, causes bone necrosis through the 3 enzymes, the collagenase, acid phosphatase, and proteolytic enzymes, which are released by the osteoclast and the mononuclear inflammatory cells. So that is why this squamosal type has a bone destroying property through these enzymes. Now, hearing loss, it is more as compared to mucosal, and most of the times it is conductive. And sometimes the patient, they're complaining of bleeding from the ear, which can be because of the granulations and the polyps present in the ear. Now, so when a question is asked that what are the causes of blood-stained ear discharge, then the answer should be granulations and polyps present in the squamosal type of CSOM. And another cause of blood-stained ear discharge, it is malignancy of ear. So in malignancy also we can get blood-stained ear discharge. So on otoscopic examination, we may see a perforation, but here the perforation is not central. Unlike in mucosal type, it is either atic or it is posterior superior marginal perforation. Or we can see a retraction pocket. Now, the grading of the retraction pocket, there are two classifications. If a retraction pocket is present in the attic region or in the pars flaccida region, then there is TOS classification. And if the retraction pocket is present in the pars tensa region, then there is SEDES classification. Now here TOS classification will apply because we are talking of the retraction pocket in attic or posterior superior quadrant. Or we can see a frank cholesteatoma, which is seen as a pearly white flakes. So any of these pathologies can be seen on otoscopic examination in cases of squamosal type of chronic otitis media. Again, how to manage such case? So as I told you earlier, also examination under microscope is very important in any case of ear disease because it gives us details about the pathology, the structures involved, and to an opportunity to clean the ear under microscopic vision. Then tuning fork test. So we should do that series of tuning fork tests starting from 256 Hz, 512 and 1024 Hz, which gives us an idea about the type and degree of the hearing loss. And to document that hearing loss, we require an audiogram. We can send the pus for culture sensitivity. And in squamosal type, most of the times we need a CT scan to assess the extent of the disease. Nowadays, X-ray mastoid, it is not routinely done in cases of squamosal type. We are more in favor of HRCT, high resolution computed tomography of temporal bone to know the extent of the squamosal type of otitis media. Now, there are certain clinical signs and symptoms which indicate that this patient might be having some complication because we know that complications are more commonly seen in squamosal type as compared to mucosal because of the bone destroying property of the squamosal type. So what are those signs or what are the symptoms that can give us an indication that this patient might be having some complication? Now, if apart from the routine ear discharge and decreased hearing, patient also complains of pain, which may be located deep inside the ear, it may be located around the ear, then it may be an indication of some abscess in the brain, which can be extradural. It can be a perisinus abscess or even in brain abscess. So there'll be pain. If a patient complains vertigo, then it may indicate that there is a formation of fistula over the lateral semicircular canal. Now, fistula is most commonly seen in lateral semicircular canal. If the patient complains of persistent headache, it can be a feature of any intracranial complication. And if we can see there is any facial paralysis or facial weakness on one side, then it means that the disease has eroded the fallopian canal and affected the facial nerve. Then if a patient is a child who is listless, refusing to take feed, and easily going to sleep, it means he is not very active, not responding. It can be a sign of extradural abscess. Then if there is fever, nausea, vomiting, it can be seen in meningitis or any intracranial infection secondary to ear pathology. If neck rigidity, Brudzinski sign, they are elicited, then it is meningitis. If the patient complains of double vision, then it can be Gradenigo's syndrome, which is seen in petrositis, where there's involvement of sixth nerve, fifth nerve, and ear pain. So the involvement of sixth nerve will cause lateral rectus palsy, which will cause uh, diplopia, and that is called Gradenigo's syndrome. If cerebellar signs are present, like ataxia, then it means that the patient is having cerebellar abscess. So presence of these signs and symptoms in a case of CSOM should alert us that these are signs, these can be signs and symptoms of the complications, especially in cases of squamosal type of otitis media. Now, it is not that the complications are not seen in mucosal type, but as compared to squamosal, the complication rate, it is less in mucosal type of chronic otitis media. So what is the treatment? So again, the primary aim of any ear surgery, it is to remove the disease. Now, depending on the extent of the disease, the procedure can be canal wall up or canal wall down. Canal wall up means here we are talking about the posterior canal wall. So if we are keeping the canal intact, this is also called intact canal wall procedure, or if we are removing the posterior canal wall so that the middle ear and the mastoid become a single cavity, then it is called canal wall down procedure. Now, there are various factors which decide which procedure to be done. It depends on the experience of the surgeon. It depends on the extent of the disease. Okay. Now, the differences between these two procedures are the meatus, the external auditory meatus, it is wide in canal wall down procedure, while the anatomy, it is normal in canal wall up procedures. So we can see that the canal wall up procedure, it is more anatomic. I mean, after surgery, the ear will be almost similar to normal, but here there will be a wide meatus. Now, the canal wall up procedure, they do not require regular cleaning because the cavity is very small. Now here, because we have a very big cavity, we have made a single cavity for antrum and middle ear. So it will require regular cleaning because there will be formation of crusting. There can be formation of wax or discharge. So it requires regular cleaning. That is called cavity care. Then chances of recurrence and residual, they are very high in canal wall up because here we are working with limited exposure. So there are chances that in inexperienced hands, the disease may be left over. But here, because the exposure is more, the cavity is large, chances of recurrence or the residual disease, it is less. That is why generally in Indian settings, because the compliance of the patient is not so good, many of times we prefer doing canal wall down because in the second, I mean, here we can see that the second look surgery is generally required in canal wall up procedures, which can be scheduled after 6 months of the first surgery. But in canal wall down, generally it is not required. Now, in Indian settings, we see that the patient compliance, because of the poor socioeconomic status, the patient compliance may not be very good. Hence, they may not be ready for a second look operation. That is why we prefer canal wall down. The routine physiological activities like swimming, they may be restricted in canal wall down procedures because the cavity size is more, chances of water entry into the cavity are more, which may lead to infection. However, there are less chances of water entry when canal wall up procedure is done. Hearing aids, if required after surgery, they can be easy to be worn in canal wall up procedure because we saw that the meatus size was normal. But in canal wall down procedure, because the meatus is very large, the hearing aids, now we know that they are very compact and small hearing aids. There can be problem in fitting or using those hearing aids. So these are the pros and cons of the two procedures. Some examples of canal wall down procedure, it is episiotomy or radical mastectomy and modified radical mastectomy. Then after mastectomy, we need to reconstruct the ossicular chain and the tympanic membrane, which can be done, that is myringoplasty, or along with ossicular reconstruction, tympanoplasty. Now, there can be some cases in which either the patient may not be ready for the surgery, the patient may not be fit for the surgery, or we may feel that currently the squamosal disease is in inactive stage, so we can um, we can wait and watch. So in very limited number of patients, there can be conservative management in squamosal, but that is not a routine. In most of the times, we need to immediately go for surgery, that is mastectomy with tympanoplasty. That is the surgery of choice for squamosal type of chronic otitis media. So finally, in this table, I have discussed the differences, the key differences between the mucosal and the etiquental. So this tubotympanic, it is mucosal, and etiquental, it is squamosal. With respect to discharge, we can see that there is profuse discharge in tubotympanic, which is mucoid and non-foul smelling or odorless. While the discharge of etiquental, it is scanty, it is purulent, and it is foul smelling. Perforation, it is always central in mucosal. It can be attic or marginal in squamosal. Granulations, not commonly seen in mucosal, but they are very commonly seen in etiquental disease. Polyp, if present in mucosal, it is generally pale, while a polyp in squamosal, it is red and fleshy, which leads to the blood-stained ear discharge. Cholesteatoma, it is always a feature of squamosal type of chronic otitis media. It is not seen in tubotympanic disease. Complications can be seen in both the diseases, but they are more commonly seen with squamosal type of otitis media. The reason I have told you that it has bone destroying property. And hearing loss, when seen in an audiogram, generally it is of less severity or less degree in mucosal as compared to eticoenteral type of chronic otitis media. So these are the key differences between these two pathologies. And thank you very much for your patient listening. I hope I have covered most of the aspects. As I again told, I told you that this is a very important topic. So if you have any queries, please, most welcome. You can put it in the comment box and I'll try to address each query. So thanking you again very much. Thank you for your patient listening.